All right, thank you very much everyone for joining. My name is Ud Bavram. I am a fifth year undergraduate at McMaster University. I've been here at UAB in the Department of Radiation Oncology for the past couple of years, working here as a kind of co-op student, and really I'm here to tell you about all the projects I've done over the past couple of years, enabled by, of course, Dr. Cardenas, Dr. Pogue, and so many others in the department. So yeah, with that we'll get right into it. So I'll talk about a little bit about the auto segmentation project we had published last year. Then I'll talk a little bit about the Ethos 2.0 high fidelity mode study that went out earlier this year. Then I'm talking about the latest paper that we've been working on, so that's quantifying inter-observer variability in adaptive APBI, and finally finishing off with improving nomenclature standards using large language models. So the first paper is here. It's published in Intelligent Oncology last year, towards the start of the year, and it's called Assessing Quantitative Performance and Expert Review of Multiple Deep Learning-Based Frameworks for Computed Tomography-Based Abdominal Organ Auto-Segmentation. Yeah. So the title's a bit of a mouthful, but hopefully I'll be able to demystify that a little bit. And this was with Dr. Cardenas, Dr. Pogue, and a couple of our physicians. So the first question is really, what is AutoML? So you'll hear me talk about this a lot. Auto machine learning, in other words, is just a way for us to automate the entire ML process. So when you think about normally how we train machine learning models, we really have to put a lot of work into curating the data, and then fine-tuning that data, choosing a lot of the parameters. Things like that just take a lot of time, or is a very tedious process. So AutoML pipelines just automate that entire process. You give it a certain set of data, it will return to you a trained model that will make all those decisions for you in terms of hyperparameters and all these sort of things. And so for us, it was we pass through the images, we get a model out. And so the question is, okay, well, we know this exists, but there are quite a few of them that exist, and which one is the best? And so in this corner, we kind of have MonAI Auto3DSeg, and so this was relatively newer at the time that we looked at it. It had done very, very well at certain competitions. So first place in the Hector 2022 competition, which is head and neck. Second place in the Instance 2022 competition, and first place in the IELTS competition. So it was a new contender, but it had shown very, very good progress compared to the existing standard, which at the time was something called NNUnit, and this continues to be one of the most widely used AutoML frameworks in image segmentation. And so this won 9 out of 10 challenges at the MCI 2020 competition, and won 5 out of the 7 at MCI 2021. And the first place was first place at the AMOS 2022 competition. And AMOS, of course, is abdominal multi-organ segmentation. So this is the competition that we're particularly interested in. This is what all of our data is from. And so in order to evaluate the model, we took 200 labeled abdominal CT masked pairs from that AMOS competition. We compared them using DICE, surface DICE, 95th percentile Hausdorff distance, given the masks that we got out. And we also did an additional qualitative physician Likert scoring for those specific models. So what we can see here is kind of an example of the output that we would get. So we have our NNUnit predictions, or Auto3DSeg predictions. We included a baseline non-AutoML model, in this case a SWIN unit R, as a kind of benchmark baseline, and then we had our ground truth, so the actual true mask as provided to us by the competition. So you can kind of see how they match up. They're all relatively similar, fairly pixel peaking. You can see some bits of difference there, but really they were very similar. And so the question was, well, okay, which one's better? Now the results for us were pretty interesting. So we found that there was significantly better performance by both AutoML methods compared to the standard non-AutoML methodology. We also found that NNUnit was significantly preferred over Auto3DSeg. So we can see kind of across the two categories, DICE, Hausdorff, and surface DICE, there was significant preference towards NNUnit in all three of those metrics. Now what we also did was qualitative comparisons. So we looked at the sliding scale, which we gave to physicians, and NNUnit was significantly preferred over Auto3DSeg. So Auto3DSeg, 87% of contours scored about a 4 or above, and NNUnit, 89% of them scored a 4 or above. So really minor or no edits needed. And so what we ended up showing is that AutoML frameworks provide a much more time and resource efficient manner of achieving clinically acceptable results with significantly better contours than non-AutoML frameworks. And the second paper here is something pretty cool. Is a kind of involvement across the department and across our lab. So I'm pretty grateful for this work having been enabled. And this is entitled Dosimetric Evaluation of Ethos 2.0 High Fidelity Mode for Single Isocenter SRS. We published this in JCMP just a couple of months ago. It came out in print, so that's pretty neat. So for those of you who are unaware, Ethos 2.0 is the second generation of software provided to us by Varian. One of the big talking points for them was high fidelity mode. They said, they promised us it would give us steeper dose gradients, it would have improved conformity, it would reduce normal tissue dose, and these are all things that made our ears perk up as physicists, because these are all things that we would love to see in any of our plans, or at least have the option of seeing. And so theoretically, we thought, okay, well, wouldn't this lend itself better to SRS-like plans or SBRT-like plans? We know that Dr. Pogue showed that there were significant effects for less complex adaptive plans on IUAV1, and one of the big talking points about high fidelity mode was that it would significantly reduce plan complexity. So this is another endpoint that we wanted to evaluate. And really the rationale, especially here in Alabama, is that we have a lot of patients who are large body habitists, and what that means is they wouldn't necessarily fit the weight limits on the bed for something like an edge. Whereas the Ethos, being halcyon-based, does support up to 505 pounds, so it would support even the largest body habitus patients. And so the question really wasn't, can this replace our current SRS program, but rather, can this provide SRS, or a reasonably good SRS, for folks who wouldn't meet the criterion for SRS on the edge, and who would otherwise have to deal with whole brain radiation. And so really, the final point that we kind of evaluated was, how does high fidelity mode work in conjunction with the planning rings that we used to use internally to try and force the system to generate SRS-like points. So does it work better with them, without them, and so on. And so what we did was we took 50 patients, which were delivered 30 gray and 5 fractions. And we had 15 tuning patients, and we said, okay, well, we'll take those out of the 50 patients, and we will tune them on all 4 of these different training templates. So high fidelity on, rings on, high fidelity on, rings off, high fidelity on, and so on. And so all the 4 permutations. We would tune them and we'd see, okay, well, are these generating plans that are clinically viable? And once we had a plan that we were pretty happy with, we then applied that to the remaining 35 tuned patients, and we extracted quantitative metrics from those plans. And so those quantitative metrics look something like this. So in this case, I'm only showing you conformity and fall off across the 4 different plan types. And what we can see is that high fidelity on, rings on was significantly better than any of the other plans. In fact, high fidelity off, rings off were actually the worst plans out of all 4. Further, we found that there was significantly less plan complexity with high fidelity mode. So this further backed up the claims that Arian made. And we interestingly found that rings actually don't affect plan complexity. So between the two, between changing rings on or off, we didn't actually have any significant changes in plan complexity. And so qualitatively, what that kind of looks like is something like this. So we can see all the 4 plans here for a given patient. In this case, it's single isocenter. There are multi-targets on the same slice or on the same level. So we're pretty interested in seeing how the system performs in this kind of case. And so what we can see visually is a lot of that bridging there, especially in between those two, because of the purely coplanar beam geometry, it's hard to reduce. But we see the high fidelity mode does a great job of really trying to pull that back and make sure that there's not as much bridging, which again is still tough, and we still see a lot, some of that bridging that we wouldn't otherwise see on the edge. But without a couch kick and purely coplanar 3-degree freedom optimization, these are pretty much as good as they'll get. And so finally, the conclusion here was that we indicated that using both high fidelity mode and the user-defined control rings resulted in improvements in plan quality, facilitating decreased healthy brain dose, sharper dose drop-off, and reduced plan complexity compared to any of the other planning strategies that we investigated. The third paper is something that we're working on now. It is very widespread across the department. So I'm very, very pleased and very grateful to all of our collaborators for helping us out with this. The title is Evaluation of Inter-Observer Variability for Ethos Adaptive Accelerated Partial Breast Irradiation Plans. And so really there were 2 clinical endpoints for us. So one was, can we quantify this inter-observer variability in the CBCT-based adaptive APBI plans across multiple professional groups in order to inform optimal margin selection. The second endpoint for us was, can we quantify the workflow impacts between the various professional groups? And so what we started out doing is we have this SIM CT. So again, we have the GTVs delineated by the physician on the actual SIM. And we say, okay, well, daily we take another adaptive CBCT. And what Ethos does very kindly for us is auto-propagates the SIM CT onto our daily adaptive. But we understand that due to the nature of the adaptive treatments, these contours aren't always correct, especially with seroma volumes. And so what that means is often our physicians are sitting at the machines recontouring and tweaking the contours a little bit just to make sure that it really does match up to the daily anatomy. But the question really for us is, given the same starting point, so given the same auto-propagated ethos GTV, what does that inter-observer or inter-group variability look like for all of our different observers? And so the data looks something like this, where, again, originally we had the reference structures, and we had the CBCT, and so ethos does a good job of marrying those two and giving us a nice starting point. We provide that starting point, the exact same one, to all of our different groups. So we had 5 physicians, we had 3 physicists, 3 therapists, and 3 dosimetrists, who are all modifying these contours based on what they think is appropriate, and they're timing themselves. So this is, again, leading into more of that workflow aspect. Now, once we have all of their all of their GTVs, we can generate a CTV by just applying a 10 millimeter CTV onto that. But specifically with the physicians, what we do is generate something called a consensus GTV, and that effectively is a majority vote, where we'd say, at least 3 out of 5 of the physicians have to agree that a certain pixel or a certain voxel is actually diseased or not diseased. And so you can kind of see that up there in the top right. And then finally, we generate, again, some very similar consensus 10 millimeter CTV, and what that allows us to do is compare the consensus of the physician gold standard to whatever the other groups are. And we did this the same process for 14 previously treated adaptive APBI patients across 28 total fractions. And so here are the results. So on the top, we kind of see the percentage of the consensus CTV as covered by a given observer's PTV. And we kind of have these groups of observers in addition to the auto contour. So imagine someone had not touched this. What would that kind of look like? And so we can kind of see that trend where it's all normalized to 100% because obviously we can't cover anything more than 100% of the GTV. And you can kind of see that laid out by increasing PTV margin. And what we can also see is that 95% dash line, and that was made in conjunction with our physicians. And we said, hey, if someone came to you and said there was a coverage, so the observer had made a structure that covers 95% of your contour, would you be okay with that? They said, yeah, I think 95% is a good number. So that's what we're sticking with that, and that's why the dash line is up there. Now the second one really helps us to capture what the first plot doesn't, which is over-contouring. We can imagine that physicians generally would be quite tight, quite confident with their contours, whereas other professional groups would much prefer to include extra normal tissue, even if that meant they were including extra normal tissue and not actually covering just the GTV. So in this case, we can see just a simple ratio of the PTV of the observers compared to the consensus CTV, and we can kind of see as that increases, there's quite a bit of normal extra dose that's being generated. Finally, we can look at the timing. So the timing, again, very simple to interpret. We see the physicians do a very, very good job in terms of keeping it very, very quick and neat, and we can see some of the other groups struggle a little bit in that sense, and this is why we decided to look at this. We knew that looking just at contour and performance time isn't enough on its own. We do have to include this dimension because of the nature of adaptive therapy and how those contours are generated. And so our final conclusion from this was that adequate clinical target delineations can be achieved across diverse professional groups with appropriately tailored margins with considerations for extra normal tissue dosage. Finally, I'd like to talk about improving TG263 targeting compliance using locally hosted large language models. Now, this is something that won us a Blue Ribbon poster at APM 2025, something I know I'm super proud of, and I'm super thankful for Dr. Cardin and Dr. Cardenas for setting me up with this and helping me out. And so, really the question is targeting. So, this is a standard from some computer science journal way back when, or some computational biology journal that said, hey, here's actually the definitive guide on how to name your structures. And then a couple of years later, we get this. This is yet another publication that says, no, actually, this is how we name it. Now, APM then came on the scene and said, no, forget all that. This is how you name structures. And so you can already see there's quite a bit of contention in the space. And the report, the TG263 report, is 37 pages long. Now, we wouldn't expect any of you in this room to go out of your way every time you make a new structure to read through the 37 pages and ensure that it is compliant. It's just not something we would expect realistically. And so the question is, how can we help alleviate that? Now, we know that large language models have existing knowledge bases that help us out with this problem. And not only that, but they are very efficient at generative rule-based tasks. And we can kind of see some examples of LLMs here. Now, a small distinction here is that the LLMs that we're using aren't actually a lot of these. These are publicly available online LLMs, but the ones we are using are locally hosted, which means they get processed here, they run here, there's never anything that leaves our site. So that's important for us because of HIPAA concerns, but really they're very similar to all the LLMs that you will use online. Now the workflow looks something like this, where the initial word in this case was GTV_6th_rib_r. Now, I can ask any one of you what that means, and you will tell me that is a gross target volume that is located on the 6th rib, and the laterality is the right side. Now, is this TG263 compliant? Absolutely not. And so the question is, can we efficiently generate a TG263 compliant name just based on that initial input? And so what we asked the LLM to do initially is generate a description of the target, just what I gave you now. It's a gross target volume, it's on the 6th rib, and it's on the right side. And then using that description, we can then ask the LLM to fill out a JSON that looks something like this. And that JSON is just a fancy word for a structured list, and it tells us, okay, we have all these different elements that TG263 can accept. Now, which one of these would you fill in based on that description? So in this case, it knows it's a target type, so it's a GTV. It knows that there's an anatomy, so 6th right rib. And that's pretty much all we need for the specific example. So what we can do using this list is then generate the TG263 compliant name of GTV_rib06_r. Now, we wanted to validate this, so internally we went through our database and we looked at all, I think, 1,000 names that we could find that were TG263 incompliant, or that had aberrations that we wanted to take a closer second look at. And what we looked at were all of these different incorrect names and our generated compliant names. So you can see GTV rib06R right at the top, and then you can kind of see some others. But there are some that I've highlighted here, and I've highlighted this because this is an active problem that we are working on. So the question of compliance is not isolated in and of itself, because compliant does not always mean correct for us. Now, I'll give you a specific example, this PTV_RT space femur. So in this case, we generated a name that was PTV_femurs, plural, and that is a perfectly acceptable TG263 name. But we all can see the immediate effect of using an LLM to name this. So when we dug a little bit deeper, we found that it had omitted the RT because in its interpretation, in its description, it had written, oh, this is a primary tumor volume for radiation therapy of the femur. Now, we as physicists and physicians understand that that's actually not true, and that the RT refers to the laterality, in this case, the right laterality of the femur, so it should actually have been femur_R. So in this case, we can see kind of how those nuanced descriptions make assumptions that aren't always correct. And so in this case, I just want to emphasize that this is a problem we're still trying to solve. We still don't know what the best approach to solve this is. What we've tried is, passing in the surrounding structures, passing in image data, but we're still working on this. This is still an active area of investigation for us. So the moral of the story here is that consistently producing TG263 compliant nomenclature while conserving the original user intent enables significant reductions in manual user intervention and error rates, improving both workflow efficiency and accuracy. And I'd like to take a moment to highlight some of the non-research highlights, which I'm actually looking at this, and a lot of it is research. But effectively what I mean is not research here in that sense. But yeah, I'm just really, really thankful for everyone who made my stay here at UAB so successful. A lot of conferences, a lot of wonderful people I'll miss very much when I'm back out in Canada. A lot of really cool research output, a lot of posters, a lot of presentations, a lot of media attention, which I'm super grateful for. And yeah, in particular, I'd really like to thank Dr. Cardenas and Kara Bishop. Carlos, you brought me here in the first place, and I'm truly grateful for that. Obviously, Kara Bishop is our admin wizard, and she's been instrumental in bringing together all the visas and all the red tape and trying to get me through that and get me working as soon as possible. So I'm really thankful for that. And obviously, all of my other co-mentors who I've worked with, Dr. Carden, Dr. Pogue, Dr. Stanley, and so many other people. So with that, thank you very much, and I'm happy to take any questions. Thank you.